questions pane on the control panel where you can enter your question, and we'll ask the speakers a few of the questions at the end of the webinar. If we don't have time to get to all of the questions, the speakers can follow up with you afterwards by email. Today, our speakers are Dr. Colleen Witt and Dr. Robert Sheehan from Rosa. Dr. Witt has over 25 years of research experience in immunology and neurobiology. Prior to her work with Rosa, Dr. Witt worked as a research professor at the University of Texas at San Antonio and served as director for the core facility of the Specialized Neuroscience Research Program. She's been with Rosa for 9 years and has served as scientific lead on numerous modeling projects focused on disorders of the central and peripheral nervous systems, as well as other non-neuronal inflammatory diseases as well. Dr. Witt earned her PhD in immunology from the University of Alabama at Birmingham before doing postdoctoral work at the University of California, Berkeley. Dr. Robert Sheehan has over 10 years of research experience in computational and systems biology. Prior to his work with Rosa, Dr. Sheehan worked as a postdoctoral fellow at the Laboratory of Systems Pharmacology at Harvard Medical School. He's been with Rosa for 5 years and has served as modeling lead on numerous projects focused on disorders of the central and peripheral nervous systems, as well as other disease areas, including oncology and inflammatory disorders. Dr. Sheehan earned his PhD in computational biology from the University of Pittsburgh. Please welcome Dr. Witt and Bobby Sheehan. And Bobby, you're welcome to begin.
Thanks so much for the kind introduction, Mike. We're really excited for the chance to participate in the webinar series and to present our work. I do think we'll be turning our cameras off now that the introductions are done as we dive into the presentation itself. And before we really get into the details of the presentation, I do want to mention that the details of this work have already been published in a paper in CPT Pharmacometrics and Systems Pharmacology that won the 2023 ISoP Outstanding Research Manuscript Award, and which we wrote together with colleagues from Genentech and Roche, who are all listed here as co-authors. And of course, they all deserve a ton of credit for the work we'll be presenting as well. With that, we're going to start with a brief overview of some of the topics that we want to cover with this webinar. I will be going back and forth with my colleague, Dr. Witt, who will generally be explaining the biological background and scientific underpinnings of the model, while I'll generally be covering the technical implementation and simulation results. We'll be starting with some scientific background on Alzheimer's disease, followed by a summary of the model itself and the initial calibration of its untreated disease progression. Then we'll want to focus on a few key features of the model. This includes the model PK/PD, the creation of ApoE4 positive and negative virtual patients, and the role of microglia in plaque clearance. With that, I'll be turning things over to Dr. Witt. She begins to introduce the biological background.
Thank you so much, and thank you everybody for attending today's webinar. We're looking forward to this. So Alzheimer's disease is the most common neurodegenerative disease worldwide. It is the leading cause of dementia, affecting over 55 million people globally, with an estimated 10 million new cases reported each year. Shown here on the right is a hallmark feature of AD pathology, which is the accumulation of the amyloid beta protein into what are referred to as senile plaques. This accumulation is associated with progressive neurological decline that leads to dementia and ultimately death. Despite considerable investment into potential therapies, current approved treatments are limited. This is where quantitative systems pharmacology can be very useful. QSP can be used to reveal biological insight into AD pathology and can help guide the design of clinical trials. So toward realizing this promise, Rosa, in collaboration with Genentech and Roche, has built a comprehensive model of A-beta accumulation in AD. And with that, I will pass, there you go, thank you. So the model's representation includes 3 primary functional compartments: the brain, plasma, CSF, It includes transport from the brain to the CSF, as well as to the plasma, and includes transport between the CSF and plasma, as well as the peripheral compartment for antibody PK dynamics. Next slide. The model's representation of A beta production dynamics begins with its production. APP can be acted on by base 1, the enzyme, doing the first cut, to yield its product C99, which then undergoes further processing by the enzyme gamma secretase to yield, depending on its cut site, 2 distinct A beta monomer species, A beta 40 and 42, which are tracked in the model. Targeting antibodies can bind to each of these monomers to produce monomer antibody bound complexes. The model includes several clearance mechanisms, including receptor-mediated cellular uptake, enzymatic degradation, microglial phagocytosis, as well as active and passive transport to the CSF and plasma. Next slide, and with this, I would like to pass it over to my colleague.
Thank you so much, Colleen. So next we'll be looking at the aggregation of A beta in the brain, as well as its binding and interaction with monoclonal antibodies. So as Colleen said, in the model, A beta 40 and 42 are 2 separate species that both have the potential to aggregate into higher order species, first forming oligomers, and then fibrils, and finally plaque. Importantly, the aggregation rates of these 2 species are different, with A beta 42 being more prone to aggregation than A beta 40. A beta antibodies can potentially bind to any of these A beta species, with the exact affinities for each species being dependent on which antibody is being simulated. And we did calibrate the model to include a number of different monoclonal antibodies of interest. The binding, of course, can influence the aggregation and clearance rates of A beta species, with antibody binding slowing down aggregation and leading to increased clearance of fibrils and plaques, but also potentially increasing the half-life of some of the soluble A beta species. The A beta dynamics as a whole are fully integrated across all of the model compartments: the brain, the CSF, and the plasma. This includes bidirectional transport of soluble A beta species between all 3 compartments, which includes both active and passive transport and the crossing of the BBB and BCSFB. Additionally, to ensure proper concentrations and dynamics in each of the compartments, peripheral production is included and represented in the plasma compartment. The A beta species in both the plasma and the CSF are also subject to antibody binding, just as they are in the brain. However, no aggregation occurs in these compartments. In total, these mechanisms together are able to capture biologically accurate concentrations of the A beta species of interest in each compartment. And critically, these concentrations are able to dynamically change in response to treatment, allowing for the tracking of these species as biomarkers in the CSF and plasma. And these effects will be highlighted later in the presentation. Next, we'll be moving on to dive into the calibration of the untreated disease progression in the model. And we'll be passing it back to Dr. Witt to explain the biological background.
Thank you, Bobby. So PET imaging, with its readout measurement of the SUVR, has been used extensively in the field to track the accumulation of A beta over time. Work shown here by Villemain shows that A beta deposition follows sigmoidal kinetics over time. Beginning slowly at first, the accumulation rate increases over the course of approximately 19 years before it begins to level off. In addition to longitudinal A beta SUVR data, CSF biomarker data was also collected to inform model calibration. This is summarized on our next slide. Here is a summary of the key data that informed platform development. Shown are the calibration targets for CSF readouts, as well as the PET SUVR targets that were used in the platform calibration. This is just a sample of the data that goes into the model. There were over 500 papers, studies that were analyzed to inform both quantitative and qualitative aspects of the model. And I will pass this now back to Bobby.
Thanks again, Colleen. So SUVR and centiloids are both used as outputs for A-beta aggregation. They're calculated directly based on the amount of insoluble A-beta in the brain. The initial model calibration did focus on the roughly 20 years of approximately linear growth in this curve, where we expect to see about 1.3% growth increase per year. Later on, updates to the model allowed us to achieve the full S-shaped growth curve that you can see here over 50 years of progression, meaning the model is really capable of accurately simulating both short-term and long-term effects of disease progression. The A-beta monomer concentrations were also closely informed by data and carefully balanced across compartments to ensure constant levels of A-beta monomers in the absence of treatment. Additionally, the relative abundance of A-beta 40 versus 42 monomers was a key calibration target, as this ratio can play a key role in the aggregation rates in the brain and can serve as a biomarker in the CSF and the plasma. As you can see at the table in the bottom here, the simulated ratios very closely mirror the ratios that we set as targets based on the literature data. This is true across all compartments, and you can see that these are well calibrated to be at steady state on the right-hand side. Next, we'll be diving into antibody PK and PD in the model. So the antibody is allowed to travel between the three main compartments, the plasma, CSF, and brain, as well as a peripheral PK compartment, which is not shown here. The parameters governing the transport rates of the 4 antibodies we simulated were all estimated using plasma and CSF PK data constraints. We did assume that transport rates between the compartments would be identical across all 4 of our antibodies, whereas the binding affinities, half-lives, and concentration in the periphery were all unique across each one of the drugs of interest. As you can see here, the model is able to accurately capture plasma PK dynamics for 3 drugs that we show here. First, crenezumab, then aducanumab, and gantenerumab across a range of different doses. Additionally, in panel D, we can see that the model captures some of the limited CSF data that was available at the time, matching data we had for 2 different doses of crenezumab treatment. For concentrations in the brain, where there was little to no data available, we assumed that about 0.2 to 0.3% of the free concentration in the brain should equilibrate to reach steady-state concentrations of free antibody in the brain should reach about 0.2 to 0.3% of the free concentration in the plasma. And this is an important constraint, and notably, you can see the results of that equilibration in panel F here. Plaque-binding antibodies actually end up requiring often months of dosing before reaching this steady state. It's because in the first few weeks of dosing, most drug is binding strongly to the plaque, and so substantial dosing is actually required for free drug to reach its equilibrium at the level that we expect. Next, we'll look at the PD response of the model. And the simulations, again, were able to do a good job of matching some of the key biomarker data we had in response to treatment. You can see the response of A-beta 40 monomers in the plasma in response to crenezumab treatment, as well as those same monomers in the CSF. And the model is able to, again, very closely mirror the data that we had access to. Additionally, A-beta monomer data in the plasma in response to, in the CSF in response to solanezumab treatment was well captured by the model. So this supports the use of the model for tracking biomarker data in response to treatment. So next, we'll be talking about the building of our ApoE4 virtual patients. In building these 2 virtual patients, the first thing we had to do was ascertain the mechanistic difference between our 2 patient types. And I'm going to hand it over to Dr. Witt to explain that aspect of the biology.
Well, thank you. So there are several key mechanistic differences between APOE4 carriers and non-carriers. One primary difference is that APOE4 carriers show decreased A-beta clearance from the brain as compared to non-carriers. Well, shown here is a rather dense data set. It's not necessary to cover all the information here. I would like to, however, draw your attention to the final 3 right columns indicated by red and blue arrows. These data show that regardless of APOE4 lipidation status, carriers, indicated by the red arrow, retains a greater amount of A-beta 42 and incidentally 40 in the brain as compared to non-carriers, which are indicated by the blue arrows. This paper did a lovely job of showing that this increased retention of A-beta in the brain is due to decreased ISF bulk flow. Bulk flow is indicated in white bars, as well as decreased transport across the blood-brain barrier, which are indicated in black bars. Now, the data showed no difference between the carriers and the non-carriers in terms of their enzymatic degradation, clearance by degradation. Not shown in today's webinar, other data show that there is also increased production for the carrier, in that base 1 activity is increased in carriers as compared to non-carriers. So we see that we have for the APOE4 carrier, they have both increased production as well as decreased clearance as compared to the non-carriers. So next slide, it's probably perhaps not surprising that each the carrier and the non-carriers show different accumulation rates of A-beta as measured by the SUVR. Shown here is the change in SUVR over 20 months for non-carriers, shown far left, heterozygous carriers, that is carrying one allele of 4 in the middle, and then the homozygous carriers, far right, having 2 copies of the 4 allele. So with increased production, decreased clearance, carriers accumulate A-beta at approximately twice the rate of non-carriers, with the rate of accumulation showing allele dose dependency. This rate of approximately 2 times for carriers served as our calibration target when creating these 2 different VPs in terms of A-beta accumulation. All of these mechanistic differences were implemented, the increased base, decreased transport in the model to create our carriers. And with that, I will pass this back to Bobby.
Thanks, Colleen. And here we highlight in the model where we did implement these mechanistic changes that Colleen has gone over in great detail already. You can see that compared to the APOE4 negative virtual patients in the positive virtual patient in the carrier, we do increase the level of base activity here, increasing the production of C99. We're going to decrease the A-beta clearance for both monomers in the brain, and we also decrease A-beta transport, which we highlight here on the right. The degree to which each of these rates was increased and decreased was again pretty carefully controlled by the data that we found in the literature. So after we've kind of implemented what we thought to be the key drivers of the different responses between the carrier and non-carrier responses, the question remained, do these mechanistic differences fully explain the difference in the A-beta progression rates that we observe? And of course, the answer is yes. By implementing just these couple of mechanistic differences, we could see a slower progression for the negative virtual patient compared to the positive carrier. So in accordance with the data, what we see here is that the APOE4 positive virtual patient is roughly twice the increase in SUVR over 1 year compared to what we see in the APOE4 negative virtual patient. So what we thought was really key here was the implementation of just a couple of mechanistic differences that were all very well supported by the literature, reproduced exactly the expected differences in progression rates, importantly with no additional calibration on our part. So this really kind of gave us some additional confidence in the overall calibration of aggregation and transport within the model. It helped us, indicate that we weren't kind of overfit to any small piece of data set, that this model was generally able to represent the key mechanisms of biology, and that we could extrapolate out to new virtual patients for additional simulations. And next, we'll be moving into what is the final results section of the presentation, where we'll look at the role of microglia in plaque clearance. So a key piece of data that we wanted to use for model calibration were these data that came from a phase 1b trial for aducanumab, which showed the change in SUVR from multiple doses of aducanumab treatment across a number of years. But one key trend that we noticed when we were looking at this data was that the reduction in the SUVR appeared to follow first-order dynamics. And you can really see that here as we kind of overlay these dotted lines, which are meant to explicitly represent what first-order decay would look like. And it turns out these very closely mirror the dynamics that we see in the data itself. So generally, the simplest explanation you would have for this kind of data, this kind of first-order decay, would be that all of the plaque is being subject to equal clearance immediately after antibody treatment. However, what our simulations show us is that really antibody is only binding a very small fraction of the plaque. And the original assumptions that went into building the model were that antibody binding to plaque would lead only to strong clearance of the plaque that was directly bound to the antibody. So this means in our simulations, we would have expected that only a small portion of the plaque would be subject to clearance at a given time, particularly early on in treatment. And this kind of appears to be at direct odds with the data we see here. And as we move on to show some initial simulations, we can in fact see that our first run of simulations really did not match the data at all. Again, for these simulations, the plaque had to be bound to the antibody to experience increased clearance. What this means is that we saw initially a very slow initial clearance of the plaque. And eventually we would see these kind of zero-order dynamics being, of zero-order clearance dynamics across the length of the simulations. And this resulted in, a very poor fit to the early data points that we had and a poor fit to the late data points that we had. We really weren't matching the correct dynamics of plaque clearance at all here. We realized that to achieve first-order clearance, there must be some kind of an antibody effect on unbound plaque. So to address this, we needed to explore potential biological mechanisms that could explain these first-order dynamics. And Dr. Witt is going to explain a hypothesis that we came up with. Colleen?
Yeah, thank you. And I do want to pause here to say that this is really a good example of how modeling and biology can work so wonderfully together, and that the process of building a model, it's not just about the end product, but the process of building that model can be so useful in revealing insights. So one explanation, first order clearance, could be explained by the nature and the phagocytic capacity of microglia. So for example, an antibody is only about 10 nanometers wide, whereas the amount of matter that an activated microglia can engulf can exceed 800 square microns. And this is due to the extensive membrane spreading shown here on the left. And incidentally, when a microglia is involved in phagocytosis, its entire membrane becomes involved. Not just the external membrane of the glial cell, but its internal membranes can actually be recruited to give even a greater surface area to engulf its target. So that's one thing, just thinking in terms of the size of the molecule that we were talking about, the antibody, compared to the, let's say, the size of its bite. In addition, the average size of a plaque, shown here on the left is a size distribution of senile plaques, is about 400 to 450 square microns. So here again, we see that the size of the volume that can be engulfed in a single event far exceeds the average size of plaque. So what does all of this mean? It means that the antibody to, or I should say the engulfed volume to antibody is far, far greater than what you may intuitively appreciate. I will add that I think a reason for that is the way that we present it in the literature. In order to show the antibody in any diagram or cartoon you see in a study, the antibody is enlarged to this ginormous molecule so that you can see it in the activity of phagocytosis. But we forget that the scale is completely different than that. So considering this biology, it led us to a revised implementation of antibody-mediated clearance. And I will give this back to Bobby. He'll explain that.
Thanks, Colleen. So here we can see some results actually from the implementation we came up with. So in this implementation, we did change the model dynamics so that specifically when IgG1 antibodies were binding to plaque in the brain, it would induce microglial activation, and the amount of antibody binding would correspond to the strength of microglial activation in general. And then once they're activated, these microglia will able to clear all plaque, not just the antibody-bound portions, which was true in the initial simulations that we showed. We calibrated this microglial effect to some data from aducanumab and crenezumab's clinical trials. And you can see here in these new simulations that we're doing a much better job of fitting the data, particularly to the aducanumab simulations, which were the same data that we failed to fit in our initial simulations that we showed previously. You can see that, in fact, there is still a lag in achieving the maximal clearance rate, which gives us kind of a slow initial start to plaque clearance in the model. In the platform, this is really due to the delay in antibody reaching steady state in the brain. We do believe that a more mechanistic representation of microglial activation and recruitment could improve this fit, particularly if we were to consider an initial burst of activity that microglia are expected to show once they've first been recruited and activated. But generally speaking, a more mechanistic and detailed model of microglia would be a great addition to better capture all of this data. We will also note that strong clearance was not seen in the crenezumab data or simulations on the right-hand side. And while there are a number of differences in this antibody, one key one I think is that the that has an IgG4 backbone instead of an IgG1 background. And we believe that this suggests that the IgG4 background does not induce as strong microglial activation. And this is another difference that we're able to capture in the platform, and that can be continued into future simulations. And next, we can see the application of this newly calibrated model to some additional data, an extra kind of test and qualification step for the platform to see if following calibration to one data set, can we match additional clinical trial data that is available. First coming from some newer phase 3 aducanumab clinical trials on the left-hand side, as well as some gantenerumab clinical trials on the right-hand side, both of these being similar acting plaque targeting antibodies with an IgG1 background. And you can see that the model is doing a very good job in these predictive simulations, still capturing the data that we see. There's still somewhat of a delay in the clearance that we see in our aducanumab data, but overall, we're doing quite a good job of matching the data that you see here. And similarly, for the gantenerumab data on the right-hand side, the model is able to capture these dynamics very well, which gives us confidence, again, that this model is extendable and can be used to simulate plaque targeting antibodies with significant reliability in the future. With that, we'll pause for a quick summary of the results and some ideas for future directions we have. So in conclusion, our team built a mechanistic QSP model of the A-beta dynamics in Alzheimer's disease that's able to capture disease biology and the interaction with therapeutic antibodies. By implementing the known mechanistic difference between ApoE4 carriers and non-carriers, the model is able to accurately match the respective A-beta accumulation profiles in 2 distinct virtual patients. And finally, plaque clearance dynamics of gantenerumab and aducanumab suggest that the clearance of the bound and unbound plaque are increased by IgG1 antibodies. This is a key factor in the response to treatment with monoclonal antibodies, and microglial activation proportional to the plaque binding of these antibodies is consistent with this pattern. And the great thing I want to point about a QSP platform like this is that this kind of model takes a lot of time, a lot of effort, and a lot of resources to build, but it's truly extendable. And our model, we believe, is well positioned to explore many new research questions of interest beyond what we showed here. Now that we have a well-calibrated model, we could easily add additional disease mechanisms to the platform, things such as tau pathology, which of course are of great interest to the field. There are many known interactions between A-beta and tau, with A-beta, anti-A-beta treatments that have been seen in the clinic to reduce tau in the CSF. Additionally, phospho-tau in the CSF and plasma are key biomarkers, so adding this additional disease mechanism and its interactions with the A-beta mechanisms in the platform already would be a very obvious and significant addition to a platform-based model. The mechanistic connections between the A-beta clearance, microglial activation, and ARIA could also be explored. There's still a lot of open questions about exactly what the timing and degree of the microglial activation might look like and how we could capture that in the model. Additionally, what other hypotheses might be consistent with the response to plaque binding antibodies? Are there other kind of important pieces of the biological puzzle that should be added to the model? And finally, this kind of microglial activation and resulting inflammation could certainly lead to ARIA, which is a very key side effect and negative outcome that is of concern in the clinic. And there are a lot of ways we could use simulations to try to optimize the balance of plaque clearance versus ARIA instances. Additionally, in this version of the model, we've really kind of focused on disease pathology, but connecting the brain biomarkers that we have to real cognitive outcomes would be a very logical next extension, especially if we can help to pin down what aspects of the A-beta pathology could be driving correlations with cognitive outcomes, and can we accurately predict those? And finally, leveraging the model to better explore antibody delivery to the brain. Something that we've really come to discover in our simulations is that small changes in antibody concentration in the brain can have pretty significant effects on outcome. And of course, this is something that would be very difficult to measure in the clinic. So better understanding the amount of antibody that reaches the brain could really be key to defining correct dosing regimens and would be something that could be easily explored through additional simulations. With that, I want to thank everyone for their time and their attention to this webinar, and thank Colleen for her expert biological advice as well. And thank Mike for moderating the discussion. And I'll pass it back to you, Mike, for any questions that we have from the audience.
Thank you, Bobby. Thank you, Colleen. That was excellent. We do have a couple of questions from the audience. So one is one you were just referring to. Was antibody binding expected in the brain? I believe the answer is yes, but earlier slides suggested that binding was only considered in the CSF and plasma. So can you clarify that?
Yes, the antibodies in the model are certainly capable of binding to A-beta in the brain. And we did consider, different antibodies that have different binding profiles. So aducanumab and gantenerumab that we focused on at the end are primarily binding to plaques, and they're certainly binding in the brain. Other antibodies that are binding to soluble species, such as the monomers and oligomers, they're binding in all 3 compartments, in the plasma, the CSF, and in the brain.
Thank you. Next question is, how did you make assumptions about the fraction of plasma concentration? I assume this means of antibody that goes into the brain.
That one was certainly a difficult question. There's some literature data, I think, based somewhat on animal studies and some clinical studies as well that seem to generally point to this kind of window that seems agreed on by a number of people. Potentially 0.1, 0.2, 0.3% of what you're seeing in the plasma getting into the brain. I don't think that was a super tight constraint. I do think it's something that could potentially vary across antibodies too. So it's a really key uncertainty in the model, I think. I think the values that we settled on were based on some minimal data, and I think they set reasonable bounds, but I think it's a really key area for future exploration. Colleen, do you have any additional comments?
I just wanted to second that the literature, there does seem to be a consensus that it varies between 0.1 and 0.3%, and that was primarily arrived at from animal models. But it is an often quoted percent penetration into the brain.
Thank you. Next question is, do you happen to have, I think it's for Colleen, do you happen to have the reference for the paper that shows that ApoE4 carriers increase production of A-beta?
Yes, that is off the top of my head. That's a Stockley. Here, I'll give you, if you'll give me 1 second, I will pull up that paper and give you the exact citation. Okay.
Next question is, could a bystander effect activate non-antibody binding microglia, such as other mediators or mediators near the microglia activated by the antibody bound to plaque?
So that's definitely something we considered, and I'll jump in while Colleen's looking up that reference. We've certainly considered it. I think we would really love to do an extension on this model that did a much more detailed model of the microglia themselves and their activation, which would include, the changes in inflammation, additional kind of recruitment and activation of other cells. I think that kind of expansion of microglial activation through a bystander effect, that seems like a possibility for sure. But the implementation in the platform is quite simplistic right now, just to kind of capture the general idea of more antibody binding to plaque leads to more microglial activation as a strict correlation. Colleen, if you're available, do you have any other thought on that kind of bystander effect?
I wouldn't use the word bystander effect. It's that there are many in vitro studies that have shown that once a microglia cell has been activated, it is completely capable of phagocytosing A-beta in vitro without antibody. And there's just a number of in vitro studies of that. And the reasons for that are varied. Some of the reasons have to do with the recruitment of other types of receptors and involvement of other complement-related receptors. So again, the bottom line is once it's activated toward a target, there can be phagocytosis in the absence of antibody. Incidentally, I do have the Stockley paper. Should I
yes,
respond
please,
to that at this point? So when we do these analyses of papers, it's not simply reading the paper. There's often data included that's not necessarily spelled out for you in the paper. The paper is from John Stockley et al. Cora O'Neill is the final author. This is from Feb's letters in 2006. And if you look at specifically table 1, they have a number of individuals with the genotype, the APOE genotype listed, whether they are an E33 a double homozygous carrier, that would be a non-APOE4 carrier. They have a table listing out the genotypes. What we did was to compare all of the listed non-carriers to the carriers. And the other data contained in the table was the Vmax, the Km, and for base 1. And you can tell, you can look by comparing the carriers to the non-carriers, the difference in these values for base 1, leading to the increased activity claim.
Thank you. Okay, next question is, could you share your thoughts on what the influence is of affinity to the different species? So monomer, oligomer, fibrils and plaques, what the influence of affinity is for efficacy for the different compounds used in the analysis.
That's a good question. I think a lot of our simulations kind of showed that affinity to monomer and oligomer did not have very substantial effects in reducing plaque burden. To some extent, you could slow down further accumulation, but it made it difficult to have enough antibody building up in the brain, I think, to have a significant effect on plaque, on really clearing and reducing plaque burden. And I don't think we had a feeling that there was any kind of benefit to it necessarily, rather just a potentially a negative impact. I do think binding. Yes.
No, go ahead.
Okay, I was going to say fibril versus plaque. I think I've definitely seen another number of antibodies in the field that have differential effects on binding solely dense core plaque versus binding fibrils as well, or both. And I think there's some benefit to binding and clearing out the fibrils. There's a lot more information that we haven't shown here that we can still get into the details of, but I think binding fibrils really helps to slow down progression at the same time as really starting to clear out the insoluble pieces that are becoming the building blocks for plaque, and I think does a key role in also that there's enough fibrillar mass to really give you a lot of binding target that helps increase microglial activation as well. So I'd say that there's real benefit to having an affinity for the fibrils as well as the plaque. Colleen, do you have additional thoughts there?
I think you've covered that. No, I don't have anything to add.
Okay, so next question is, what is the rationale for IgG4 and IgG1 difference in their ability to clear A beta plaques?
I can answer that. It's the ability of one antibody's backbone to activate the receptor. So it's all about the backbone's ability to activate the Fc receptor.
Okay,
and Colleen, correct me if I'm wrong, but I think there was some hope that the IgG4 antibodies would be less likely to induce ARIA and brain inflammation,
Correct.
But it seems like that can come as a trade-off versus getting more efficient plaque clearance.
It absolutely comes as a trade-off because it makes common sense, really, that the greater the activation, the greater the clearance, but the greater the activation, the greater the chance and risk for ARIA. And toward that end, well, I'll just stop with that.
Okay, next question. The model assumes the same intercompartment transport rates for all monoclonal antibodies. Have you considered using different rates to capture the delay in reaching maximum effects?
So we did. There was actually kind of a long story in the calibration of some of those PK dynamics. But what we found was that we didn't really have kind of strong rationales for a lot of those rates to be different overall, and we were really able to capture the PK data well by allowing all those rates to remain constant, which kind of reduced some of the assumptions we felt like we were making. In terms of getting that kind of initial bump, I suppose, and getting a faster clearance and getting a target, I don't think that that's a realistic path. I don't think it's likely that there'd be enough of a difference that would really kind of give us enough of a boost to microglial activation the way it's currently implemented in the model to explain those early data points. For that to happen, at best, you would have to have kind of a huge influx into the brain and have it kind of stick around there to show that. And even then, I'm not sure it would work. I think realistically, that's going to be better explained by the microglial dynamics because, again, we obviously don't have good profiles for exactly what the antibody time course should look like in the brain, but I think the ones that we have right now are relatively reasonable, and you would have to get such a big difference to really capture those early data points for plaque clearance. I don't think that would be a change that would solve the problem.
Thank you. There's a question about the process for building a complex model like that. This is from Dr. Mustafa. I think I'll refer you to the white paper on the model qualification method. You can find the citation on the Rosa website. First author is Christina Friedrich, our chief engineer, that talks about the general process for building a QSP model like this. But the next question specific to this presentation is regarding microglia induced by antibody. Has this been confirmed with in vitro data? And does it mean we do not need high drug concentrations in the brain in order to clear A beta plaques?
Antibody-mediated clearance has definitely been shown in vitro. However, you need an initial activation event. I don't know that you would get, if I understand the question, are you asking, and the questioner can clarify, whether or not the antibody is necessary to mediate microglial clearance? Is that the
I think the question is whether you need high drug concentration if you're getting initial activation.
No, and there's this brings up a kind of a tangential topic, but having antibody in the system at all can activate macrophage in the periphery, and there is a outstanding debate as to what degree peripheral macrophage that have become stimulated by the administration of the antibody enters the CNS to in the process of recruitment to assist in the clearance of plaque. Now, that is an ongoing topic of research, whether or not that is a major contribution to clearance or not. But even if there is no peripheral recruitment, once you have activated microglia in the CNS, regardless of recruitment, they produce a variety of pro-inflammatory cytokines, which will recruit other microglia from different areas of the brain to the site. So you need the initiation event. That's what's key. Once it's been initiated, the inflammatory response with or without recruitment from the periphery is quite significant. And therefore, the good news is you don't need to flood the CNS with the antibody. At least that's how the data and simulations appear to indicate.
And I really think that this model with just a little bit of extension on microglial biology or other similar models would be a really good avenue for trying to kind of optimize that process to better understand the direct exposure response relationship you would see in the brain, and how much antibody do you really need to get significant response, and how long do you need it to be present to kind of maintain that response. I think simulation is a great way to optimize that question and to kind of ensure you're using the right doses and not overdosing.
Thank you. You mentioned receptor-mediated endocytosis as a clearance pathway. Which receptors and cells do you have in mind here?
RAGE is a receptor, but there are also astrocytic receptors. RAGE is also expressed on astrocytes. So astrocytes play a role in taking up A beta in the CNS. And there's a variety, LPL, which one is it? Now it's, of course, it's going to slip my mind, but the receptor is expressed on glial cells, play a big role.
Thank you. The first data sheet, next question. The first data sheet you showed suggested that the A beta concentration is growing again. I assume that means after initiation of treatment. Can you confirm that the questioner's interpretation is correct, and how would you interpret that pattern? And if it's something you need to think about, we can also follow up offline.
I'm not
Actually,
sure.
my audio dropped for about 8 seconds. Can you repeat that question, Mike? I apologize.
Yes, the first data sheet that we showed in the slides suggested that the A beta concentration is growing again. Would you confirm this? Is that the correct interpretation, and how do you interpret that? I think they're referring to after initiation of treatment.
Yeah, I'm not exactly sure which one they're referring to. I can try to jump.
You can look through the deck.
If you'd like to follow up, we can do it offline.
Possibly. There's certainly, in effect, the two things I can think it's mentioning are, and I'm not sure what the first data sheet is. possibly one of these. I mean, I will say that, when we're looking at the SUVR or senoids representing the plaque aggregation in the brain, they're certainly all growing over time in general. And you can see that in some simulations here that there's, without treatment, there's certainly growth. And even with treatment, you're seeing a little bit of growth at the beginning. Something else we do know occurs is that when you take away antibody, generally you're going to see a rebound effect and additional growth at the end. Those are two possibilities, but I'm not entirely sure what's being referenced.
Okay, thank you. There is huge variability in data. How do you reconcile all the different reports? Have you explored variability?
Oh boy, that's a great question. I'm glad somebody asked this. I'll speak to this one. I'm going to use the CSF as an example, because depending on the capture antibody, depending on the methodology, you get all kinds of a wide variety of levels of A beta in the CSF. Again, this has to do with different methodologies as well as different capture antibodies to measure the A beta level. So when it comes to to get around that, to come to what we do for the CSF biomarkers is we usually resort to looking at fold change, because remarkably, despite the fact that the methodologies are very different and you have a wide variety of levels, the fold change in A beta in the CSF is remarkably invariable. There's not a lot of variability when you look at that. So that's one way. Another way, when looking at data that in completely a different methodology, you have to look for the trend. You have to look for there's an increase. This increase is some fold increase. And once again, referring to or resorting to fold increases when you have a wide difference in absolute values is a really helpful and sometimes necessary technique of analysis. This is where also why we like to pride ourselves here at Rosa of having a team of scientists that are well experienced in research methods and that can offer insight and interpretations into the data based on the different methodologies. And you need those kind of expertise to discern which methods are better to weigh over others.
Yeah, that's absolutely a critical part of our workflow. We wouldn't be able to do it without the really direct expert scientific input in interpreting all the research, data that's available out there. From a modeling standpoint, the other thing that I just mentioned that we often do for handling that level of variability or uncertainty is just virtual patients or virtual populations. We don't have exact examples that represent that here, but it wouldn't be uncommon for us if there's a really wide range in data for a really key driver of disease or target of drug, for us to have a couple of virtual patients that, that exhibit the low end, the high end, and the average. And we can first of all just test, is there significant difference in either disease progression or response to treatment across those virtual patients to assess, how important of an uncertainty is this? Is it something that we really want to try to nail down, or is it an important variation in the population that might need to be addressed in different ways? So using virtual patients and populations is the key way for us to try to control for some of that variability that, just can't be hand waved away.
Okay, thank you. Next question. Some people, we have time for just one or two more questions. So some people think that activation of microglia is a double-edged sword. What's your opinion on this? Do you think there's a threshold of microglial phagocytosis which predisposes towards A beta plaque?
Absolutely. This is such an important sticking point in the literature and in the active research in the field. You're absolutely right. Microglia are indispensable on the one hand for clearing A beta, in particular during an acute inflammatory phase. However, chronic activation of microglia can lead to extensive damage to the tissue. An uncontrolled chronic inflammation is believed to be responsible for quite a bit of the death that we see in neuronal death in the tissue. So on the one hand, you absolutely need, it's a primary clearance mechanism, but on the other hand, too much of a good thing leads to the damage. And it's an important aspect that Bobby said earlier. One of the ways that we could use this model, or a model like this, is to enhance this aspect of the model to extend the biology of the microglia component and explore these questions, because there is evidently a balancing act that must be struck to get the good side, the good aspect of microglia activation out, but without invoking this chronic inflammatory response. And incidentally, once they're chronically activated, they don't even clear up very well. Anyway, they become engorged and are doing little good at that point. It's a very good question.
Thank you. Last question here. I'm not sure if this is going to be a Bobby question or a Colleen question, but for the microglial effect, is it possible that a spatial effect is important? It could be that microglia have a local effect and are recruited to the site of the plaque by the antibody. Is there interest in studying the spatial aspect, perhaps with an agent-based model?
Perhaps with an agent-based model? Well, first of all, this absolutely is happening, and I'll let Bobby speak to this too. We do know that initial activation is a local event. However, due to what I was saying earlier, an activated microglia sends out signals to the neighboring areas and to far-reaching areas of the CNS, so there's recruitment to that site. Bobby, did you want to speak to this question?
Yeah, I think the spatial considerations are really interesting and could be really important. I think there are interesting questions on how well does the antibody kind of speckle and cover across the plaque versus getting stuck in different areas, and are the microglia broadly recruited kind of across the regions you're interested in? And we've talked about kind of the three-dimensional spatial aspects too, of once you're kind of getting outside layers of the dense core plaque, are you then kind of getting at the deeper layers as well, and do you need additional antibody binding? Modeling the spatial aspects can definitely be tricky. I think the agent-based approach would definitely be interesting here. Traditionally you might think of, PDEs to cover spatial constraints. That's not going to scale to this kind of a complex model at all. Having just more of a compartmental-based model where you had multiple brain regions could give you some additional resolution, and I think would be an interesting approach. But agent-based modeling, it would definitely be interesting, and I think some of the potentially stochastic nature of understanding, being able to simulate where the antibody is going, where the microglial are going, and what effect that has on overall plaque clearance. I think that could be a really interesting area of study.
All right, well, at this point, I would like to thank the speakers, Bobby Sheehan and Colleen Witt, for their excellent webinar presentation. There were some additional questions, which I'll share with the speakers, and they can follow up offline with you. Want to remind you that this is a monthly series, so be looking for the announcement for next month's webinar in your email. Thank you for joining, and we'll speak with you next month.
Thank you so much, everybody.
Thank you, everybody.